Lysosomal storage disorders, MPS, Module 4, Lecture 2 in the genetic series. The lysosomes, I like to think of the lysosomes as the garbage disposal of the cell. They are intercellular organelles, and they contain a number of enzymes used to catabolize proteins, nucleic acids, lipids, and complex carbohydrates to smaller components. Each lysosomal enzyme reduces a particular macromolecule to a smaller component, and these smaller pieces can then be eliminated from the body. Our cells are a lot greener than we are. Defects in various enzymes in this pathway results in accumulation of either carbohydrates, lipids, nucleic acids, whatever the enzyme is responsible to break down. As a result, these larger particles stay in the lysosomes, and then the lysosomes become non-functional, and then they're discarded. The whole cell is discarded because the lysosome kind of takes over the cell. There are over 40 different lysosomal storage disorders, and they're under the big umbrella of an inborn errors in metabolism. Genetic defects resulting in deficiency of a particular enzyme is the cause. In most cases, they're inherited in autosomal recessive fashion. The incidence of all lysosomal storage disorders put together is approximately 1 in 7,700. If you put this in perspective, cystic fibrosis is 1 in 3,000 in Caucasians, and Down syndrome is about 1 in 700 to 1 in 1,000, but 1 in 100 to women over the age of 40. So certainly not as common, but very important, and also on the boards. The most common of the lysosomal storage diseases is Gaucher's disease, and this is one you definitely need to know. This is followed by Sanfilippo, but part of the reason Sanfilippo was number 2 is because it actually represents a number of different forms of it that are really different disorders. And then we have syndrome, which is MPS, followed by Niemann-Pick and Fabry's, which we're going to be discussing in the next lecture. Unfortunately, the least common is Tay-Sachs. Why is it important to think about a lysosomal storage disorder? Well, over the past 10 to 15 years, a number of new treatments have become available. So the earlier the patient is diagnosed, the earlier we can start a treatment. There are many genetic disorders that there's not actually a specific treatment if you diagnose it, just that you know what it is, but this is an exception to that. So what to think about a lysosomal storage disorder? Well, non-immune hydrops, a baby that's edematous before birth, organomegaly, enlargement of the liver and spleen. I always like to think of the liver and spleen as the as the garage and the basement of the body. You know, whenever we don't know what to do with something, we shove it in the garage, we shove it in the basement. Well, that's our liver and spleen, where we shove stuff when we don't know what to do with it. Unexplained joint stiffness, again, these cells that accumulate affect the joints. Coarse facial features, especially if it's worsening, and we're going to discuss that in this lecture. Unexplained pain in children, burning, neuropathic pain. And finally, loss of developmental milestones and progressive dementia. This can be a sign of a muscular or neurologic problem, but it's one thing to be moving forward. That's known as developmental delay, but it's far more concerning if someone is moving backwards. That is known as a loss of milestones. That is a sign of a storage disorder. So I'm going to go over a case. A 9-month-old comes for a well child check. His mother's concerned he has some delays. He sits unassisted but is not pulling to a stand. He's not crawling. He babbles, but he doesn't say mama, dada. He reaches for objects with an open leg dress, but he was born at 32 weeks gestation, so he's 7 months corrected. The weight is 10 kilos or 95th percentile. The length is 75th percentile. However, he has macrocephaly or hexacomics greater than 95th percentile. He has tubes in his ears because of chronic ear infections and a lot of nasal congestion. He's got some wheezing with good air entry. The abdomen is soft, but the liver is enlarged at 1 centimeter below the costal margin, so you should not be able to measure the liver below the costal margin. And there's a firm mass on the back in the midline. And so here's our patient. He's kind of cute, but he actually does have coarse facial features, and we're going to discuss this. He's got a depressed nasal bridge. And I want you to look at this nose, kind of the upturning of the nostrils here, a large tongue, kind of bushy eyebrows, a low hairline, broad stubby fingers, and a little bit of an umbilical hernia, also a protuberant abdomen. So we're going to talk about the gibbous. This is actually a different picture, but of a different patient. But the gibbous is a structural kyphosis. It's this sharp angle curvature in the spine here. It's formed because of collapsing of the vertebrae bodies, causing kind of a wedge deformity. And it's easiest to see when the patient is leaning forward. So mucopolysaccharide disorders, or MPS I, is known as Hurler, Hurler-Scheie, or Scheie. So, in glycosaminoglycans are used for tissue support. Lysosomal enzymes are responsible for the degradation of these glycosaminoglycans. And the enzyme deficient in MPS I is alpha-1 iduronidase, which is right here. The arrow somehow switched over. Other enzyme deficiencies that result in other mucopolysaccharide disorders. So there's a lot of steps in going from this large chemical to something that's excretable. And it's the second step, which is iduronidase, alpha-1 iduronidase, which is not working in Hurler syndrome. So the genetics of MPS I is autosomal recessive. There's more than 50 different mutations. But unlike many other disorders, we can't predict severity based on genotype. Carriers are asymptomatic, so if you have one functioning copy of this gene, you're fine. And again, it's a defect of the enzyme alpha-1 iduronidase and affects all ethnic groups equally. On exam, again, the four core facial features, you can see the similar nose, the full cheeks, the bushy eyebrows, flat face, prominent forehead, large head, the macrocephaly, thick lips. They're normal at birth, and it becomes more prominent as the child ages. Here's another contractures because of the accumulation in the joints. So here's a picture of a little girl. Here she is at 10 months. You can kind of see that nose, but I don't think anybody else would consider her coarse. And here she is at 12 months, looks pretty normal. Here she is at 22 months, and you can see how the hair is getting kind of coarse, the eyebrows are getting a little thicker, the cheeks are getting fuller, and here she is at 39 months. You can now see the lips are getting fuller. I always say that the ophthalmologist is my best friend because, especially with storage disorders, the cornea is a very thin membrane, and it's sometimes the first place that we see things. So we have this kind of ground glass appearance. They can also get glaucoma, retinal degeneration, and optic nerve disease. Ears, nose, and throat, or ENT, chronic rhinitis. These accumulated cells result in obstruction, chronic rhinitis, chronic sinus infections, loud breathing, chronic ear infections or otitis media, chronic hearing loss, poorly formed teeth. The respiratory manifestations, these glycosaminoglycans use large carbohydrates deposit in airways, and this can result in a stiff or floppy trachea, both of which are not good. Enlarged tonsils and adenoids, frequent infection because you're not clearing your secretions, cardiac cardiomyopathy, enlargement of the heart, valvular disease, these things are accumulating on valves, high blood pressure or hypertension, coronary artery disease, and this is actually the common cause of death in these patients, is the cardiovascular manifestation. Gastrointestinal or GI, and enlarged spleen and liver. Like I said, these are where we store things that we can't get rid of. There's problems with the connective tissue. The umbilical and inguinal hernias are often sometimes one of the first signs, especially of recurrent umbilical hernia. They also have a lot of diarrhea. So we discussed the gibbous already, but they can also have abnormal clavicles. They can be short and thick, hip dysplasia. And here's the claw hand deformity. And this is as much as this individual can extend their elbow because of the accumulation of these products into the joint. Central nervous system, progressive developmental delay, communicating hydrocephalus, progressive MR, speech delay, language impairment, and again, loss of milestones. So, urine glycosaminoglycans, or GAGs, are an inexpensive screening test when considering a mucopolysaccharide disorder. Both dermatan and heparin sulfate are elevated in patients with MPS I. These shouldn't be seen in the urine, but when they're elevated in urine, it's a sign that those are some of the byproducts that aren't being broken down and excreted into the urine. Enzyme analysis for those specific enzymes is needed to confirm the diagnosis, and most patients have less than 1% of enzyme activity. So, severity of disease. So we talked about Hurler-Shea, and Shea. The amount of enzyme activity, those with a little bit of enzyme is Shea, no enzyme is Hurler, and somewhere in between, Hurler-Shea. And again, these were named prior to us knowing about enzymes. They were named by people. Treatment, managing symptoms, enzyme replacement, and bone marrow transplant. A bone marrow will have in their white cells the enzyme necessary that can get to all the other body systems, so this is actually an option for treatment. Enzyme replacement, Aldurazyme, has been approved for clinical therapy. It's infused on a weekly basis. Early studies have shown patients, when we give the enzyme exogenously, to have an improvement in the enlargement of the liver and spleen, as well as affecting the skeletal features such as the accumulation in the joints. The problem is it does not cross the blood-brain barrier. Patients with Hurler and Hurler-Shea usually are able to myelinate their brain with the enzyme activity that they have. So this is actually an outstanding treatment for them. However, patients with Hurler syndrome that have zero enzyme may continue to have progressive cognitive delay. Hunter syndrome is another of the mucopolysaccharide disorders. It's excellent recessive. Occurs in about 1 in 100,000 live-born males. It only occurs in males. It looks similar to Hurler's, but presents a little bit later, between 2 and 4. Again, female cures are usually asymptomatic. So clinical features, similar to Hurler's: progressive developmental delay, hearing impairment, progressive thickening of the heart wall, growth deficiency, aggressive behavior. They have something called dysostosis multiplex, which is a thickening near the rib. But unlike Hurler's, there's no corneal clouding, and this is a board-like question when you're differentiating Hurler's from Hunter's. They may have progressive visual loss because of pressure on the optic nerve, but they don't have corneal clouding, as is commonly seen, again, with Hurler syndrome. And they can have this unusual nodular skin lesion, and this is also only seen in Hunter syndrome. In Hunter syndrome, it's actually the first enzyme, iduronate iduronate synthetase, which is deficient, and so it's the first step. So Hurler's is this step, Hunter's is this step. So, question: a 2-year-old male is found to have developmental delays, an umbilical hernia, and contractures of the joint. Ophthalmologic exam is normal. Urine for glycosaminoglycans shows elevation of heparin sulfate, of both dermatan and heparin sulfate. Which of the following is the most likely diagnosis? Hurler syndrome, Tay-Sachs, Fabry's, Hunter's, or Gaucher's? This concludes this lecture. You can go on to the actual lecture to find out the answer.